We would like to thank the RACS ASC organizers for the opportunity to present our work titled Total Neoadjuvant Therapy versus Chemotherapy during the wait period versus Standard Chemoradiotherapy for locally advanced rectal cancer. My name is Sergei Bedrikovetski, and I'm a member of the Royal Adelaide Hospital Colorectal Research Group. A little bit of background to our study. We've been using personalized TNT routinely at both our institutions, the Royal Adelaide Hospital and the St Andrews Hospital, for the treatment of locally advanced rectal cancer since 2019. In April 2012, a study known locally as the WAY trial was conducted to determine the impact of additional 5-FU with leucovorin during the wait time after chemoradiotherapy in locally advanced rectal cancer. The aim of our study was to compare the current treatment response rates with BTNT versus chemotherapy in the wait period or standard chemoradiotherapy. This figure shows the 4 treatment types in our study. In blue, we have standard long-course chemoradiotherapy administered from weeks 0 to 6, followed by surgery at week 16. In green, we have the experimental arm of the WAY trial. Patients undergo long-course chemoradiotherapy, followed by 3 cycles of bolus 5-FU given at weeks 8, 11, and 14, and patients undergo surgery at week 16. In red, we have personalized TNT treatment for patients with distant failure risk. Patients undergo induction chemotherapy. That can be 8 cycles of FOLFOX or 6 cycles of CAPOX, followed by long-course chemoradiotherapy. In the 10-week waiting period between end of long-course chemoradiotherapy and restaging, patients can undergo oligometastatic resection if indicated. Patients are restaged at week 38. If patients achieve a complete clinical response, they undergo non-operative management, and if there's residual disease, they undergo surgery. And lastly, in yellow, there's the personalized TNT treatment for patients with local regional failure risk. Patients undergo long-course chemoradiotherapy followed by consolidation chemotherapy, and they're restaged at week 32 with the same options based on the protocol. With regards to methodology, our study design was a multi-center retrospective cohort analysis. Our data came from a prospectively collected data for personalized TNT treatment between 2019 to 2022, and we have randomized controlled trial data from the WAY trial collected between 2012 to 2014. Our inclusion criteria were patients with rectal carcinoma below 12 centimeters from the anal verge receiving neoadjuvant therapy prior to surgical management. These patients are clinically staged T3, T4, or any node-positive disease. Exclusion criteria were age and stage 4 disease, and our primary outcome was complete response rate, defined as complete clinical response plus pathological complete response. Table 1 shows our results for baseline characteristics. We found a significant difference in clinical nodal staging and ASA score. Table 2 shows response to treatment. And for our primary outcome, we found that personalized TNT treatment showed a significantly higher complete response rate in comparison with the other groups. We also found that BTNT had a higher complete clinical response rate in comparison with the other groups. Table 3 shows surgical outcomes. We found a significant difference in days to surgery. Patients undergoing personalized TNT treatment had a longer period of time between end of radiotherapy to surgical resection in comparison with the other groups. We found a significant difference in procedure. That 25% of patients underwent exenteration in the personalized TNT group. With regards to pathological outcomes, there was no significant difference in any of the pathological outcomes between the 3 groups. In conclusion, BTNT results in a significantly higher complete response rate in patients with locally advanced rectal cancer and may facilitate non-operative management and organ preservation. Thank you very much.